Hello, I am Dr. Ganesh Guru. I am practicing in Sree Balaji Medical College for 3 years. I have published around 6 to 7 articles. My personal interest is oriented towards surgical gastro and surgical oncology. As we talk like oncology is mostly towards head and neck, I am here to discuss about the oral cavity carcinomas. Let's go into the lecture. Today my topic is infectious diseases, pre-malignant and malignant lesions of the oral cavity. First of all, what is oral cavity? You people have any idea about what are the boundaries of oral cavity? Typically, oral cavity starts from the vermilion border of the lip and ends in the posterior 1/3 of the tongue. In the upper surface, it is a junction between hard palate and soft palate. So shall we recall again, it is like vermilion border of the lip. In the floor is from until the anterior tonsillar pillars. At the floor, it is from the anterior 2/3 and posterior 1/3 of the tongue. So this is the border of the oral cavity. Oral cavity has actually 8 subsides. The subsides are lip, upper lip, lower lip, gingiva, buccal, retromalignant tigone, and alveolus. Base of the tongue, floor of the tongue. Typically people include oropharynx into oral cavity also, but here we are talking about primarily about oral cavity, but we will discuss more upon the oropharyngeal carcinoma also. Then going to the etiological factors, it is a typical mnemonic of 6S, that is smoking, salted, sprited, smoked food, syphilis, submucosal fibrosis. When we are coming to the risk factors, we'll start with the tobacco. Tobacco in any form, like smoking or non-smoking, is a cancerous lesion. Other factors is like alcohol. Like alcohol along with the smoking is a synergistic factor. Suppose if the risk factor of smoking causes cancer is 2 times, along with the alcohol it comes to 4 times. The other thing which is very common in the Indian and the Asian population is the betel leaf chewing. Betel leaf along with the areca nuts and slake lime together forms a particular composition. This will lead to submucosal fibrosis. Submucosal fibrosis is a pre-malignant condition which is actually not related with tobacco. It is mostly due to only this areca nuts. Under the Indian population, we have the typical tendency to keep the betel nuts on the lateral border of the tongue and the cheeks, where it leads to cancer lesion. Other risk factors comes to infectious diseases. Infectious diseases are a human papillomavirus and Epstein-Barr virus. These are of specific importance. HIV virus is also involved in the infectious causes. Other thing is syphilis. Now comes to the infectious causes like human papillomavirus. Human papillomavirus, there are various strains. Out of it, 16, 18, 31 and 33 are mostly involved in the oncological reasons for carcinoma. Among this, our specific interest is 16 and 18. In this, more specific is HPV-16. You people have been traditionally trained in the Indian society that HPV-16 is associated with cervical carcinoma, but now in the Western world, it is proven that HPV-16 is most commonly associated with the oral cavity compared to the cervical carcinoma. The recent Indian screening program is about screening of cancers for lung, breast, as well as cervical carcinoma. But since this HPV-16 is causing oral cavity carcinoma also, they are about the agenda is going that they should include this carcinoma in screening also. So HPV is more prevalent and HPV is important cause of these oral cavity carcinomas. Other viruses are Epstein-Barr virus, human immunodeficiency virus, other infectious agents, commonly we call Candida albicans and syphilis. Candida albicans is a fungal infection. It mostly arises in the immunocompromised patients. It is like an opportunistic infection. The current modern day practice, like where everyone is prescribing antibiotics for a simple lesion. So when you are giving antibiotics for any lesion, it will induce fungal infection. So you people, before prescribing antibiotics to any patient, give a second thought whether this antibiotic is absolutely necessary or not, whether the patient is literate enough to continue the course of antibiotics in spite of stopping it in the midway. So if any antibiotic is started, it should be started at a proper dose, appropriate dose, and specific antibiotic for specific infection, and complete the course. In this modern world where everyone just going to the medical shop and getting antibiotic, they are actually increasing the fungal infection. So if you go again the pathophysiology, how the infectious agents causes infectious organisms due to the chronic infection, and they have oncogenes in their body. Okay, this will lead to persistent inflammation. This again will lead to epithelial hyperplasia, dysplasia, leads to atrophy, then oxidative damage, along with the genetic factors like P53 mutation, retinoblastoma gene mutation. The most common inherited mutation, you people have any idea about it? It is like CDKN2E. So any head and neck carcinoma, if it is an inherited head and neck carcinoma, it is CDKN2E. Familial atypical mole melanoma syndrome. This is caused by CDK2NA. So these are the important genetic factors you should be knowing about it. It's like in exam, if you are writing what are the genetic mutations you know, you people should mention CDKN2A, then fancy mutation, this typical tumor suppressor gene P53 that you should be mentioning about it. Then comes the pre-malignant condition. Pre-malignant conditions, we will consider pre-malignant into 3 categories: high risk lesion, intermediate lesion, and low risk lesions. High risk lesions are erythroplakia. Erythroplakia can be homogeneous or heterogeneous. What do you mean by homogeneous? What do you mean by heterogeneous? Homogeneous is uniformly red patch. Heterogeneous is the red patch either mixed with the leukoplakia or leukoplakia on the base of erythroplakia. If you came across a common population that erythroplakia is more prevalent than homogeneous erythroplakia is more prevalent than the heterogeneous. But we consider the risk factor erythroplakia as a more tendency to become a cancerous lesion compared to the homogeneous erythroplakia. The other thing is proliferative varicose leukoplakia. If you just segregate the words, you will understand what is proliferative varicose leukoplakia. Leukoplakia is a white patch which cannot be clinically or pathologically categorized into any other lesion. Varicose lesion is like a warty-like lesion. So it is a proliferative warty-like lesion with white color. It usually arises on the lateral border of the tongue. Wherever in the subsides of the oral cavity it arises, it is usually unilateral, like single lesion. It won't be bilateral or multiple lesion. But if it occurs in the gingiva, it is the only subsite where if you are getting a PVL, that is proliferative varicose leukoplakia, it will be like multiple. And the one more typical thing about PVL, it is not associated with typical etiology. The other thing is chronic hyperplastic candidiasis, that is the fungal infection which we are talking about before. This also appears in the same white color. Then how you people will differentiate between leukoplakia and then candidiasis. Leukoplakia cannot be rubbed off, whereas candidiasis can be rubbed off. And mostly leukoplakia will occur on the lateral border of the tongue. Candidiasis will come on the central part of the tongue. So once again we will repeat the iris lesions. The iris lesions are erythroplakia, proliferative varicose leukoplakia, chronic hyperplastic candidiasis. Then comes to the medium risk lesion. Medium risk lesion 2S, oral submucosal fibrosis and syphilitic glossitis. As I mentioned before, submucosal fibrosis is common among the Asian and the Indian population, typically in the South Indian population, where we people have a tendency to chew betel nut, like betel leaf, areca nut, slake lime. This is a typical composition. We are chewing it, we are keeping on the lateral border of the tongue, gingivobuccal sulcus, where it leads to ulcerative lesion. It progressively leads to carcinoma. What is actually carcinoma? Like squamous cell carcinoma, what do you think is the reason? Anyway, there is a chronic inflammation, chronic irritation, it will lead to squamous cell carcinoma. One more important thing we can discuss about here is the entire oral head and neck cavity. The epithelium people you will commonly find is a ciliated transitional cell epithelium. But the most common carcinoma people are finding is squamous cell carcinoma. Other low risk lesions are oral lichen planus, discoid lupus erythematosus, discoid keratosis congenita. Then comes the cancerous lesion. The types of carcinoma we people talk about here are the skin and cutaneous lesion, that is squamous cell carcinoma, basal cell carcinoma and melanoma. But inside the oral cavity, if you go drill in it, mostly we'll get squamous cell carcinoma. Other carcinomas like adenocarcinoma, transitional cell carcinoma, we will be getting a wide array of the classifications. Comes to the incidence. So till now we have discussed about the type of carcinomas. Then we'll specifically come about more into its carcinoma. So coming to the incidence, there is a slide. It is a self-explanatory. You people go across the slide. But well, I will tell the clinical significance. Most common carcinoma in the worldwide, the question is like that, it is lung carcinoma. If the question is specifically most common carcinoma among the worldwide in females, it is breast carcinoma. In males, it is lung carcinoma. Second most common carcinoma among the world, it is oral cavity carcinoma. In Indian population, it occurs typically lateral border of the tongue. Coming to the OPD, with some lesion in the tongue, like avulioproside. Like any lesion in the tongue, if they are asking avulioproside, it is like a triple examination. Clinical, like history and clinical examination, followed by imaging, then the tissue biopsy. So typical clinical symptoms, what the patient will be complaining. The patient will be complaining of an ulcer, which is painful, bleeds on touch, may not bleed on touch, or any swelling, which is constantly causing trouble to the patient. The patient might be having dysphagia. The patient may not be able to take oral feeds, and vague symptoms like loss of weight, loss of appetite, this also presents in the carcinoma. So we will delve more into the imaging and the investigations. Clinical science, you people go to the morning lectures like where the clinical science are more relevant. Now we'll come into the imagings. Like imaging, if you look up at, like previously oral pantogram was commonly used. Oral pantogram is nothing but an X-ray which is covering condyle to condyle. Then comes bedside clinical investigation, that is USG. Ultrasound is a basic bedside. So it will give us from where the lesion is arising, what kind of lesion it is. It is an acute lesion or chronic lesion, solid lesion or abscess. And we can also examine across the neck region to find about the nodes and everything. So once USG has given a specific thing, we can think about whether to proceed with the CT or MRI. If you are more thinking that it's like a bony lesion, then we'll proceed with the CT. But if you are thinking about the nerve involvement, soft tissue involvement, then going on to the MRI will be like a better cause. Nothing like CT is superior than MRI, MRI is superior than CT. Both are complementary to each other. So our investigation pattern, if you go across, it will be like first basic mandatory thing is history and clinical examination, followed by the imaging, and the imaging first thing is USG. Then based on our USG findings, we'll either go with the CT or MRI. Once this gives about a diagnosis around 90% of the causes, but still we want to, it is a carcinoma and we want a tissue diagnosis to prove it. That comes our third, that is histopathological examination. Usually for this head and neck carcinoma, oral cavity carcinoma, we'll be preferring an edge-wedge biopsy. Edge-wedge biopsy means taking the biopsy which includes the edge of the lesion as well as the surrounding normal tissue. We are taking the edge of the tissue, that is because the edge contains the proliferative lesions. Center of the lesion, there will be necrosis, so we may not get the diagnosis what we are expecting, and we'll be having a normal tissue to compare the diagnosis with the adjacent normal tissue will be there, and this cancerous lesion will be there. So we'll be having a tissue to compare it. So I'm once again summarizing it. So patient comes to clinical OPD, you are having history, clinical examination, having a particular idea that this might be malignant lesion, this may not be malignant lesion. Based on that, we will go for USG. USG will specifically point out this is the site, this is a lesion, is there any multiple sites or not. Then we will think about the neck region. Based on the USG findings, we are proceeding either with the CT or MRI. If it is a more of bony lesions, we want to know the vascular involvement, we will go with the CT. If the nerve involvement is suspected, soft tissue is suspected, we will go with the MRI. Once this, up to this, like around 90 to 95% of the diagnosis is confirmatory. But still to proceed on the treatment, we will go for a tissue diagnosis. Tissue diagnosis, FNAC people usually don't do. If your primary lesion, you are strong with the carcinoma by biopsy, then for notes, we can just go with the FNAC and predict it. Biopsy, we prefer edge-wedge biopsy to have normal tissue for comparison. Edges are usually very proliferative. Central, you will be having a necrotic lesion. In certain areas, even image-guided biopsy is also allowed. Then comes to the staging. There are a variety of staging, but we will stick on to the standard AJCC 8th edition staging. In oral cavity lesions, TNM staging. T1, T2, T3, T4. T1 is less than 2 cm, 2 to 4 cm, greater than 4 cm. T4A and T4B. T4A is removable adjacent structures. T4B is usually non-removable adjacent structures. Non-removable structures include masticator space, pterygoid plates, skull base, internal carotid artery. So I am repeating it once again. T1 is less than 2 cm, T2 2 to 4 cm, T3 greater than 4 cm, T4A and T4B. T4B involves unremovable structures. They are masticator space, pterygoid plates, skull base, and in cases encasement of the internal carotid artery. In the T stages, specifically in the oral cavity in the 8th AJCC edition, they have included depth of the invasion. So depth of the invasion is like less than 5 mm, 5 to 10 mm, greater than 10 mm. So when it comes to the group staging, you will consider both this. Like if you want to tell a carcinoma at T1, you should tell like it is less than 2 cm and the depth of invasion is less than 5 mm. T2 is greater than 2 cm and the depth of the invasion is more than 5 mm. Any one of this is applicable. If suppose a lesion is 1 cm and the depth of the invasion is 6 mm, then it comes under T2. It is not under T1. Suppose if the lesion is more than 3 cm and depth of invasion is less than 3 mm, it comes to T2. So you people should include both, like what is the size of the lesion, what is the depth of invasion. Then comes to the nodal staging. When it comes to the nodal staging, the particular thing you should be knowing. 2 viruses we have specifically mentioned. One is Epstein-Barr virus, other one is human papilloma virus. The nodal staging for the non-virus thing is different and for viral thing is different. Non-viral thing actually has a bad prognosis. If the carcinoma arises due to the human papilloma virus, it has a better prognosis. Nodes due to viral invasions are usually like cystic in lesions. Nodal staging is like N0, no nodes, N1, N2A, N0, N1, N2, N3. We are having sub-classifications in it. N2 consists of N2A, N2B, N2C, N3, 3A, 3B. Like how is the easy way to remember? We will start from the N3. If any nodes clinically having a extra capsular invasion, like you are able to palpate the nodes, adherent nodes, mated nodes, it directly comes to N3B. Any node size more than 6 cm comes to N3A. Then we will slowly reduce it, like all the nodes less than 6 cm. If it is contralateral side, then it is N2C. Only the same side, multiple lesions are there, N2B. Single lesion less than 6 cm, N2A. Now comes to the N1, any nodes less than 3 cm, single ipsilateral is N1. Then metastasis, M0, M1, involvement of adjacent node. Now after staging lesions, we will come to the treatment parts. Treatment for the oral cavity cancer predominantly is like surgery, followed by radiotherapy. Then in certain situations, we will give chemotherapy. Now the recent trend, we are having genetic studies and we are going towards the immunotherapy. Grossly speaking, stage 1, 2 cancers, we will go for surgery first, then followed by chemo and radiotherapy. For stage 3 and 4, we will try chemoradiotherapy. Then if the tumor is responding properly, then we proceed on the surgery. So there are 3 typical terms for the induction chemotherapy and combined chemoradiotherapy. When you will give induction chemotherapy, what is combined chemoradiotherapy? Usually in head and neck carcinomas, the predominant treatment is surgery. Compared to chemotherapy and radiotherapy, the predominant treatment is surgery. And the second aspect is radiotherapy. Chemotherapy is usually not advised before. But now in like stage 3 and 4 carcinomas, people are trying chemoradiotherapy. That is combined cisplatin. Like cisplatin along with radiotherapy will give it. If the tumor is responding well, then you will proceed with the surgery followed by radiotherapy. So what are the cancers we should think about giving chemoradiotherapy? Typically T4A, T4B. These lesions are very big lesions and the extensive nodal involvement. These are the things we will try. Comes the induction chemotherapy. Induction chemotherapy is like where only give chemotherapy and respond how the tumor is responding. Then based on that, we will proceed with the surgery. Then comes to T1 and T2 carcinoma. In T1 and T2 carcinoma, you will go for a wide local excision, giving a pathological margin of 5 mm and a gross margin of 1 cm. What do you mean by pathological margin and what is gross margin? Gross margin is like you are operating on the tumor, cutting during the surgery, intraoperative time, you are seeing that the normal tissue, you are taking 1 centimeter. It is assumed that beyond the tumor, you are given a margin of 1 centimeter. That is gross margin. Pathological margin is like the pathologist examining the slide and they are telling the tumor free margins are 5 mm everywhere. Once the surgery is over, then the pathology specimen is coming like T3, T4 lesions, extracapsular invasion, node positive disease, margin positive, close margins, all this will proceed with the radiotherapy. The chemotherapy of choice is cisplatin based chemotherapy. Radiotherapy, it is like protons, neutrons and electrons. Electrons are usually used for very superficial tumors. Neutrons are used for salivary gland tumors. Protons are used for like where the tumor is very close to the vital structures. Protons actually has a Bragg peak effect. If you give radiation, they produce certain amount of destruction. Follow that, suddenly they will like it is a Bragg peak effect. Just you go across a textbook, then you read about the Bragg peak effect, you will be knowing about it. So we have seen a gist of the treatment, but the treatment is very extensive. You people go and read the book once again, you will be able to understand. By this note, I am ending my lecture today. We will see some other day.